Thank you for the invitation. I just wanted to say that Drs. Amin, Saranto, and White have really raised the bar, and we're looking to do our AIM symposium, and it'll be very tough to match the quality here. The second point is no one can rib like Dr. Raghavan, and good luck to you as he begins here as a Cancer Center Director. So I didn't know really how to pick a flashy name for the talk. Novel therapies for metastatic melanoma is sort of too scientific. My colleagues love to say a renewal of hope, but it's been used, and it really is a renewal of hope. There are new drugs that you've seen that have really brought forth clear benefit to patients. When I started in melanoma, I was extremely embarrassed and very jealous of my colleagues in breast cancer and lung cancer and colon cancer, where the new drugs were coming in and revolutionizing success, and all cancers were looking to mimic the successes that breast cancer and colon cancer had. Well, I can tell you today that all of our colleagues are looking to mimic the success of melanoma. And you patients are benefiting from that. And it is a renewal of hope. It is clearly the beginning of true personalized therapy. That was another title that I trashed. We are finding out who responds to immunotherapy. Is it just your immune system? Does it have a lot to do with the vasculature or the high levels of vascular growth factors, which it does? Does it have to do with your blood tests? What is your LDH that we talk about? Is that how to go to immunotherapy? And it does, and we're now taking tissue and soon blood and finding your status with BRAF mutations and RAS mutations, some of the things that I will hit on today. So I started thinking where I would go, and I put up my pompous picture. Good thing Raghavan's not. What's upcoming? Well, immunotherapy has been there and is coming on fast due to the successes of ipilimumab, and Dr. Amin spoke about that. Targeted agents that we've just heard from Dr. Infante about, and I will skip over your slides that I put into my talk. Thank you very much. Angiogenesis, that has to do with vessel formation, and we've heard about Avastin in other tumors, and it's up and coming in melanoma, but other drugs that target vasculature, drugs that have made it in kidney cancer may make it in melanoma, and combinations and going further. So I thought about one of my favorite books. My brother gave it to me when I graduated med school. Oh, the places you'll go, and the things you'll see, and what will be available to you. And these things are now not just the places you'll go. Oh, you'll go to Memorial Sloan looking for a trial and be turned down, or you go. The places you'll go is you will come here, and these things are going to be here for you. There will be in every major melanoma center, and not only have the doctors made that possible, but the pharmaceutical companies have made that possible, and people like Valerie Guild and AIM at Melanoma have made it possible to collaborate in that way. The places you go, and I will not be me. As a parent of 2 young children, I think you have to realize that you are not anyone but Dr. Seuss. And then for my patients, the places you'll go, this is a great crazy illustration, and doctors put this up and go, all right, write it down and learn it and memorize it, but all you really need to know is this is your immune system. And all of those squares are boxes where we looked at therapies to interact with, to manipulate the interaction of your immune system, just like ipilimumab has. And I will tell you about ONTAC. And ONTAC is a therapy that targets your T regulatory cells. And, well, if you're not into immunotherapy, and I clearly wasn't when I began my fellowship, you think every T cell is good, every T cell is wonderful, every T cell is there, it's in the army fighting against cancer, but that's not true. You have regulatory cells that say, well, wait a minute, not too much of you. And they suppress the activation of anti-tumor effects of the T cells. And the depletion of them can help your immune system reject melanoma. So ONTAC targets a little area that's only on these T regulatory cells, and almost like a Trojan horse takes a chemotherapeutic attached to it, a diphtheria, a toxin attached to it, a diphtheria toxin, and takes it and it decreases the T regulatory cells. This is a new thought in cancer care. These antibodies that target something on a cell and carry a payload. Is it a toxin? Is it a chemotherapeutic? Is it a radiation therapeutic? And they're called antibody drug conjugates, and they're coming into the clinic before you know it. So ONTAC is internalized through receptor-mediated endocytosis, which just means it binds with the antibody, goes in, and ultimately results in cell death. That's what you want. What do T cells do? Well, they're the not so innocent bystander. When they bind to the antigen the presenting cell, that brings parts of tumors to your immune system, to your T cells, and says, go find this. Sort of like when a fugitive gets out of jail. The policeman brings up part of the clothing to the hound dogs that are looking and says, sniff this, go get this, go take care of this, go kill this tumor. And the T effector cells, those cells that are up on top and the bottom, that's what's happening there. But the T regs can bind and cause suppression, and that's clearly what you don't want. So ONTAC is getting rid of that suppression. And clearly at this point there's a first-line trial that's happening in multiple clinics that's looking at 2 different ways of giving this therapy. And that brings another point. I sort of black out when I want people to look at me. I can't do this at home, though. The understanding is that these trials, these lovely drugs that have come to you, have come through focused clinical trials. And now we're going to ask everyone to sort of wait before you get to the IPI or the BRAF drug and understand that there may be other therapies out there. So there are some trials that are looking for people to participate even before they've seen the drugs that have shown effect. IL21 is another drug. We've heard about interleukin-2. This is interleukin-21. And it is expressed on CD4 helper cells and other cells that influence the immune system. The effects on the immune cells are great. Clearly, all of this says that we don't really know exactly where it works. Ask someone to tell you how IL-2 works. We just know it works. It increases the number and lifetime of cytotoxic T cells. It increases tumor function. It increases the proliferation of helper cells and natural killer cells, and it really revs up your immune system. And in the phase 1 experience, what we've seen is clearly stability of disease and complete responses. This is now ongoing in a randomized study compared to DTIC, unfortunately, through the Canadian clinical trials program. We have this in our clinic. But what's clearly seen in these crazy lines is that once it's given, where C1 and C2 are at the beginning of it being given, it causes lymphocytes, or those cells that are attacking your cancer, to increase. So immunotherapy is not done. This is some of the early data showing a response rate of 25%, which is wonderful. we've talked about interleukins, we've talked about ONTAC. What else is there, and what is the next ipilimumab? And that is the PD1 and PD-ligand-1 drugs. As you can see, we are at a picture that shows CTLA-4 where ipilimumab targets on the left. But PD1 also works to inhibit your T-cell response. PD1 is involved in T-cell regulation. It downregulates T-cell activity on binding. It's the same story as you've heard with ipilimumab. Let me go back. Don't go forward. Sorry. It's an immunoreceptor. It negatively regulates antigen receptor signaling upon interaction with one of the two ligands. And it's promising. I will show you data that was presented at ASCO this year and data that's been presented and published in the Journal of Clinical Oncology. This was a phase 1 trial of one of the many PD1 and PD-ligand-1 targeted agents coming through. 39 patients with advanced cancers were treated. The infusions were received in dose-escalating fashion. And what we've seen is durable complete response, partial responses, and significant regressions meeting partial response. Why am I even telling you about this when we have IPI? We have Yervoy, it's there. Why are you making data when you have VHS? Well, most importantly, we have not seen those side effects that you see with ipilimumab. The grade 3 or 4, those are the ones that make physicians spring into action. There have not been those seen. Commonly fatigue and rash, rarely the hypothyroidism, uveitis, and the neuropathy, but no grade 4, no significant toxic events. And when you look at the melanoma cohort, you find that there are 15 partial responders with no responder that has progressed. There is something to this drug that is happening that is creating durable, continued responses. And that's the benefits of immunotherapy, whether it be high-dose interleukin-2, ipilimumab, this ability to have that subset of patients with the long-term survivals. If you'll think back to early this morning when Dr. Amin put up the survival curves with ipilimumab on the trials presented, he mentioned that it's the tail of the curve. It's that curve that comes in plateaus where you know those patients making it for an extended period of time really are going to not have to deal with recurrence. As physicians like to do, they like to put up pictures of tumors and really say, look, I gave you numbers, here's how it really works. This is something you can sink your teeth into. This is a patient 8 weeks post dose number 3, doing well and continuing to do well. These are the melanomas there that we're seeing, and you can see a high response rate. Again, over 50% of patients at the doses that are remaining in response and having significant shrinkage. So the conclusion is an active drug. It's another immunoantibody. Progression-free survival is great, and it promotes TIL generation and growth, and it's a natural for combinations. And we'll get to that later in the talk. The reason I put this one up there is 39 patients, one significant adverse event, which was a mild colitis, and more to come. Well, who benefits? And we're just clearly now starting to find out how we can personalize therapy with this immunoantibodies. And this is early data that was presented by Brahmer, where the patients who had, where they looked at B7H1 staining on initial tumors, and the patients that were negative did not respond. This will have to be vetted in future trials, but it is a beginning, just like when you show up and your tumor tissue is tested for BRAF. It is a beginning to have your tumor tissue stained for B7H1 and tell you may have a higher chance of responding, a way to understand where to go. All right, all the places you'll go, again, a more complicated version of what Dr. Infante showed you about all of the molecular targets that are available for targeting in melanoma. You'll see in the middle the RAS, RAF, MEK, ERK pathway, and all of those are going to be targeted. ERK inhibitors coming up, RAS inhibitors are in the clinic. And these are just a smattering of the oncogenes found in melanoma. RAS we talked about, and NRAS is common in melanoma. You don't hear a lot of press about it, but 50% of patients have the BRAF mutation. Of that remaining 50%, in cutaneous melanoma, 2/5 of them, or the other 20% of the remaining 20% of the remaining 50% have the NRAS mutation. It's a way to target. c-KIT mutations exist in chronically sun-damaged melanomas, and there are targets for them. Mutation status can tell us a lot about how patients are going to do. I didn't put this one up to make you feel down. I put this one up just to make a point. If you look at wild type, that means you don't have either mutation, and that's the green line. You see that that line does much better than the BRAF mutated patients who do not see an inhibitor, and does much better than the NRAS mutated patients. But the best line up there is the patients with BRAF mutations who see an inhibitor. And there's no reason to believe that we cannot make those same changes for a patient who has an NRAS mutation or other mutations that we identify. So this is a hopeful picture that allows us to understand what we can really do when we find those targets and target them. Clearly, we're finding out where they exist, what type of melanoma you have. It helps us to know what type of mutation you may have. And this is not just for cutaneous melanomas. My patients who have ocular melanoma show up in clinic and say, I never hear anything spoken about for us, or the mucosal melanomas. But c-KIT is a mutation seen in mucosal, and the GNAC and G11 mutations are seen in ocular melanomas. And we're finding ways to target all of them. There's some idea that possibly MEK inhibition can help with the GNAC and G11 mutations, and there's more to come. So we're not done. You're not done hearing about what is out there. ERG signaling will soon be targeted. And I mentioned NRAS. We clearly at this point have an NRAS inhibitor that's starting phase 1 trials. And it hopefully is going to be sensitive and work. But what has happened with the success of these drugs, ipilimumab and vemurafenib, is not just that patients have been helped. It is a clear signal to pharmaceutical companies that drugs are successful and can work, and it has created an arms race, as you can tell. They are rushing to help you, and they're rushing to find their own drug that can help you. So there has not been any other time where the pharmaceutical industry has been as invested in finding targets and therapies for patients with melanoma than at this time. I will flip through that slide. And this has been shown. The role of VEGF, that's vascular endothelial growth factor in melanoma, takes us to the next point of angiogenesis or vessel formation. We've known for a long time if you have higher VEGF levels in your blood, that you will not do as well. And this is a survival curve. The lower line is the people who have high VEGF levels, and they do poorer. Well, what is out there? New drugs are coming into practice and in clinical trials that are available for patients. XL184, you will hear a lot about, as it is an up-and-comer not just in melanoma, but in prostate cancer. This drug is in randomized trials in prostate cancer and is one of the only drugs in prostate cancer that has shown regression of bone mets. And guess what? Melanoma patients get a ton of bone mets. It can work. Eisai has a 70/80 drug that's being looked at in melanoma and post-BRAF failure, where some feel that there is nothing other than MEK inhibitors, and the field is wide open. This drug is a hopefully beneficial drug. So the trials are accruing and going forward. Peter Boasberg, Steve O'Day, Lynn Spittler from the San Francisco group and our group presented data of Abraxane and Avastin. You know about Avastin. It is clearly standard now for colon cancer, lung cancer, and sometimes breast cancer. It is standard for brain tumors and is showing amazing data in melanoma with initial patients having extended survivals. And this will continue to be presented and is a drug that can be available. Well, where do you go? You have all of these toys, and you have two drugs that really do work and are FDA approved. Well, the next stop is combinatorials. And I'm not standing here with a wish list. These are combinations that are ongoing now. We are not standing pat. This is the top is an article that was presented in Cancer Research and showed that BRAF inhibition enhances T-cell recognition of melanoma and doesn't affect your lymphocyte function, your immune system function. And that's clearly the idea that giving a BRAF inhibitor may increase the efficacy of Yervoy that are known as ipilimumab. And those trials are now in phase 1 and ongoing. Ipilimumab and PD1 where I began the talk, combinatorial trials are ongoing at this point. And ipilimumab and Avastin, Steve Hody from Dana-Farber presented initial data of a phase 1 trial at his center, which showed different toxicities and long duration of response. Clearly it is one combination that is being tinkered with, but is ongoing. BRAF and MEK, you've heard enough about already, but we have seen these responses. What was amazing, and I think I have it because I took a lot of Dr. Infante's talk in here. Let's move from here. There's one that is here that I liked, and it's this slide. Because these patients who had prior BRAF then responded to MEK. But on this plot is also patients who had BRAF who didn't respond or had a quick progression. So there is a clear benefit and a clear second route. This is not a drug where patients have a short response. We have had patients have extended responses after failing BRAF. You've seen that picture. I just want to touch on a subject real quickly, and this is the first time where data that's promising has been presented at ASCO this year, and that's brain metastases. It's hard to discuss the pink elephant in the room. You know, patients with melanoma have a high chance of having brain metastases either at initial presentation or sometime during their course of therapy. And it's hard when you initially meet a patient, or it's hard when you're doing well to talk about it. It's the elephant in the room. But we've changed that. It's now the stallion in the room. We've understood in some ways how to deal with it and go forward and have beneficial drugs. This was presented by the group studying the BRAF inhibitor, the GSK BRAF inhibitor. There's 10 patients treated, and as you can see, great responses lasting for an extended period of time. Clearly, there were patients who had complete response. Almost 100% of the tumors resolved. Extracranial, so in the body, response mimicked what was in the brain, and extended duration, as you can see, going almost to a year. And this doesn't stop. There are heads on those arrows. They are continuing in patients. Ipilimumab, and we took part in both of these studies that looked at patients from that were untreated. These are not lesions that have been radiated or had surgery, etc. This is baseline and week 16 responses, and extended survivals with patients with brain metastases. And the 042 study, which was just looking at brain mets that appeared and then got IPI, and 26% 2-year survival, and one that has not been seen in other types of CNS trials. So it is a renewal of hope. It is the advent of true personalized therapy. There are more therapies to come, and hopefully there will be more symposiums where I can get up here and smile and say that it's amazing and it is wonderful. And now I can turn to my other colleagues and watch their faces as they're jealous about what's happening in melanoma and questioning how they can apply it to their cancers. I hope everyone here will benefit and will leave knowing that physicians who come here today are truly humbled by where we've come in this short amount of time and where we're going together.